Hi everybody. This brings us to the last session of our myopia progression control course, and I think this is one of the key sessions because this is about how to start a myopia clinic, how we can be of help, what are the protocols that you have to set in your myopia clinic, how to start, how to draw up the sheets, how to make those, how to document as to which patient would need how to publicize, how to get patients, and what are the equipments, what are the cost, and how to start from the basic premise, or if you want to start with full-fledged equipments, what are the equipments that you would need, how to train people, where you can get them trained, and if you need any help from our side, we can get it done. Or if you want to start a myopia clinic, we can start a myopia control clinic together with you in tandem. So I think the first and foremost thing is the space. So typically, when I started a myopia control clinic way back in 2015, we just dedicated a very small 150 square feet space. Typically, you don't need a huge space. You would need a small space around 150 to 200 square feet. Now, this space, there are two ideas about myopia control clinic. One thing is that you can start it in your own clinic. You can start just next to your office. You can dedicate a space like you have a optometry room. You can have a myopia control clinic. You can make a logo. You can design a separate entity. For us, we made a separate entity. We got into the economics of it. We created a separate account system, separate everything for that. We made a small case paper for that, so that we can document each and everything into that, small things, rare things, progression. We made separate sheets for myopia control clinic, which is very important. And I think so that is part one. Part two is that if you feel that in your practice you don't have a lot of myopia patients, what you can do is you can collect 4 friends or 5 friends, rent a small place of around 400 square feet, uh, and then you can together also combine it and start a myopia control clinic. Now, why at this point of time, from purely from clinical and economic point of view, I am telling that once you start having these myopia control patients, these are the patients who are gradually going to build up your practice of laser, LASIK, and refractive surgery also. From my perspective, my opinion and my idea was always that we should work out for the children who are definitely growing despite all the best efforts. My interest in myopia basically stemmed out of my own kids who were myopic, and I wanted to do something for them. My interest in this basically stemmed out of the fact that there are a lot of patients who are pre-myopes, and we can definitely do something for that. But it is an important source of revenue, and at this point of time we have to understand that these patients are gradually going to increase and are going to form a major chunk of revenue, both in terms of clinical work and in terms of glasses. With glasses becoming more and more expensive, it is important to understand that the whole economics of myopia does revolve not only around glasses, but also in future they may need some surgeries. And there, once you have done intervention, once you have tried hard, once you have a great term with the patient, that you have worked for them, and you have talked to the patient that this is what he has and this is what you can do. So there are a lot of things which you can do in myopia. So it is not a very bad idea to if you are having a common laser center, like if you have a LASIK center of a group practice, we would be interested in joining hands with you and start a myopia control clinic in those premises itself. For us, what we did was we created a central system where the medical records was completely separate for myopia control clinic. The everything else was separate for myopia control clinic. In the beginning, if you are taking the type 1 type of practice where you want to start it in your own clinic, you can fix a date for myopia. So, like I would give an example of lot of renowned surgeons and practitioners like Dr. Vasavada. When he started working for pediatric cataracts, he designated a particular day of Wednesday, especially for pediatric cataracts. So all the pediatric cataracts will come to him on the same day, and gradually they will undergo EUA together. Like for myself, I obviously saw him as uh, one of the senior persons, and I started my ROP work only on Wednesday. So gradually what happens is all the patients who are having similar disease, similar problems, and similar success stories. So it is very, very important that your success stories of controlling the progression have to be shared with the patients. So there are two ways of doing it. One, you can go outright advertisement into social media or newspapers. So that is the straightforward way, which also there are a lot of surgeons who do it. Nothing wrong with that. I personally go a little more subtle. I try to go towards word of mouth practice. And if you gather all these patients of myopia on the single day, they would be discussing, arguing, understanding each other. Like you can have a myopia support group. Like in Western countries, they do have support groups for rare diseases. Like when I was doing my fellowship, I saw that there was a support group of aniridia support group, like Down syndrome support group. Likewise, there are craniostenosis support group, and then I found that they also have Facebook pages where they have amblyopia support groups, and the parents themselves will interact with each other about the problems of the disease, about what are the solutions there that one doctor is telling and another doctor is telling, and likewise it sort of forms a chain, and that is how you not only get more referrals, your patients are also convinced that you are doing things more scientifically. So once you fix a date, all the patients have to, as long as possible, you try to club them on that particular day. It becomes much easier for you and your optometrist also to focus on myopia on a particular day. Once the patients increase, you can take 2 days out of your practice for that particular disease, or you can appoint a separate optometrist for that. Once the patient pick up, you can make your own short format of workup. If you want ideas, we can send you the files or the format that we are using currently. Also, we are using small sheets which are there for to document progression, and initially we used to put only axial length and the spherical equivalent refraction in that, and now we also add axial length upon CR ratio in that. So gradually you can make your own format depending on what you see in local areas. Keep an open mind when we are talking about myopia. These are still early days. I would say that when you start myopia control clinic in your own city, in your own space, you will be the pioneers of doing this. This is pretty. I keep saying that as the time goes on, we are having more and more evidence of what new can be done. So never say never. Don't go with the notion that this will work and this may not work. Something is working for you, make a note of it, put a note of it, and try to accumulate those cases that this particular thing is working in this particular population set, and definitely there is something to look forward to. So keep a note of everything. Even if I am at this point of time taking a talk on this, it's not that I know everything about it. The knowledge on myopia is changing every month, every 6 months, and the whole purpose of talking about is to have interaction, to learn more finer points from everybody, and basically create a discussion on myopia, that what should be done, what are the preferred practice patterns, what do you find in your practice which is different from my practice. And that is how once we learn from each other, we have more stronger approaches, more stronger points as to what is working generally in these myopia patients. So make a short format, stick to it, and keep on adding new points to it. So that is how you can gradually build up the case sheet. This was something which we did few years back, and this is one patient, Prishi. we have the data from August 2019. So this particular patient has come routinely from 2019. So imagine the importance of axial length is that if you see, we used to at that point of time we were I think this particular first data was taken with A scan, and gradually we moved on to optical biometer, and then you see it is increasing from 24.66. So the point is that, you know, if you are taking axial length in the beginning of your practice, that particular patient you can work up even for so many years. So it is very, very important to keep doing that. And you see their axial length upon CR ratio, it is at 3.1, 3.1 here, and it gradually changes to 3.28. Very small change in axial length upon CR ratio, not a huge change, but nevertheless, you can appreciate that 0.18 diopter change in this eye, and similar in this eye also, same 1.18 has changed. So my point is that if you keep on seeing what is happening, patient has remained stable in right eye, and in left eye patient has increased from -5 to -6 diopter, and this is also reflected in the axial length. See the difference here between the two eyes and the difference here between the two eyes is pretty large compared to what it is here. So everything is there if you have data. If you don't start collecting data in the beginning itself, it becomes very difficult, to tell the patient that you are actually progressing, your number or power is progressing. So you have to collect data in the beginning itself. I don't think this is December 24, this is February 2020. Copy paste, there's some problem when they have written there has been some problem, but the point is that, you know, you have to make certain things as mandatory, and I will be telling about what is mandatory. So this is taken from practice pattern, which we had, I think there was a meeting in 2021 where we had tried to talk about what we should do in myopia and what are the must do things. I think in this must do, we should have added axial length, not corneal topography, but I think corneal topography was a good idea, and tear film assessment. So must do has this is from that particular guideline which was published in by AIOS. But I think at this point of time, what is a must for us is we definitely do baseline K, axial length, fundus evaluation. I will talk about it. Pachymetry not must do, but yes, and if you are doing central point thickness and choroidal thickness, it is good. Accommodative lag, you should try to make a idea of it, not really a must do kind of thing. Pupil size, you should definitely do it. NPC, NPN, binocular examination, definitely you should do. If you are starting some drops, you can do tear film assessment. Serum vitamin D, again, good to do, or maybe exploratory. Topography, definitely good to do. Aberrometry, not 100%, more of exploratory and research. Obviously you will be doing visual acuity, cycloplegic refraction, PMT, and give glasses, so that goes without saying. If you don't do this, then there is nothing in myopia that you are doing. So this is the most important four, and then these three, and then pupil size, binocular examination, near point of accommodation, and after that I come to this, and then accommodative lag, and then Shermer, vitamin D, maybe topography, yes, and maybe aberrometry. So peripheral refraction also, uh, more or less, if we are having a patient where you now know that he's not responding to atropine, or if he wants to have he's allergic to atropine, or you don't want to start atropine and you want to give glasses, you can definitely keep a record of peripheral refraction, as that will also be an important parameter when you have to prescribe them myopia control glasses. So I think pick and choose, but you have to make sure that you do a lot number of tests so that you create a data. NPC, NPA, once you give atropine, it becomes very, very important. Pupil size, very important if you are starting atropine. Binocular examination also very, very important if you are planning to start atropine. I think axial length is one of the topmost and most important point in the entire gamut of myopia. After cycloplegic refraction, glasses, and vision, axial length becomes the cornerstone, because most of what we are talking, or most of what we would be saying or doing, would be based on axial growth. And younger children do grow faster compared to older children, and that is why there's a range as to what exactly is a significant axial length growth. It is zero point 0.3 for younger children and zero point 0.2 for older children, like above 10 or 11 years of age. And what to do if there is no axial length increase, but the power has increased. Now this becomes a very typical question, that axial length is not increasing. Then we have to find out why exactly the power has increased, and whether it has really increased, whether we have done a duochrome test, whether we have done cycloplegic refraction properly or not. We can do it with another strong drops, try to do refraction, and try to find out why and what has changed. If there is no axial length change, then why glass power has changed. But you can see and take every patient separately, and then try to find out what could be the reason for the glass power increase. Now when I talk about more and more refinement, and that is the whole reason why I keep saying that setting up a myopia control clinic is the future, is because you see, when the industry starts moving towards a certain point, it means that the growth is leaning towards that particular point. The industry is gradually shifting their parameters into myopia, because they see a lot of opportunity, because they see a lot number of patients in myopia. Even if it is not just about revenue, there are a lot of patients who are actually suffering from myopia, and they can be treated. So even if it is not about money, it is definitely about the number of patients. It is definitely about trying to make a difference, when you can really make a difference in medical ophthalmology. So you don't really need to have a surgical expertise, or learn a new surgery, or have sharp reflexes or something like that. You can add on to your practice if you add myopia. So this is very important. This is a very important decision, that we should look towards adding myopia clinic to our practice. If you see newer biometers, they are gradually trying to add myopia as a primary point also in their armamentarium, rather in their own hardware. They have tried to incorporate a lot of things, and now biometers are able to do auto refraction also. And all this is why it is possible. See, what this is a myopia master. For suppose this is, I'm trying to show you myopia. I'm trying to show myopia master, and what it is trying to tell you is that it is measuring all the key data. It can tell you about axial length, it can tell you about refraction, it can tell you about keratometry, it will do the data analysis for you, it will give you risk identification score, it has collaborated with BHVI, it will give you a report, it will generate a report and a growth analysis as to what will it become in the future. So basically what it is doing is, it is trying to give you a full-blooded solution. Now the point is whether you need it or not. You definitely don't need a myopia master, which will cost around 30 to 35 lakhs to start a myopia practice. But once you see that there is a device which is separately available for myopia, it gives you an indication, it gives you a very good indicator that industry is definitely looking forward towards the solutions for myopia. Now this particular device will do axial length, auto ref, auto K, and axial length. After doing that, it will generate graphs, reports, so that you can tell the patient that this is your myopia report. Another machine which is very similar to this, but at half the cost, is OBM12. OBM12 is basically, what it means is that it is an optical biometer for myopia management. Now typically you see that industry is making a biometer mainly for myopia management. It will test 12 parameters, so the name is OBM12. It will give you axial length, spherical lens thickness, cylindrical power, CCT, which means pachymetry, entry chamber depth. It will give you keratometry. It will give you white to white diameter, pupillary size. So see, essentially what they are doing is, they are trying to go into myopia. See, you don't need pupil size if you are doing a biometry. Your biometer will not do it, but your topographer will do it. Now even the Vision X90 auto ref will also do pupil size. So it is not that you need these fancy gadgets, but if you are planning to buy, you should keep this in mind. Typically a myopia master would cost between 30 to 35 lakhs. They will quote at around 37 but come down to 32 to 33 lakhs. OBM 12, I think they have not, when I was talking with them, I don't think they have fixed on a particular amount of money, but it would be, I think, between 15 to 17 lakhs. I think if the machine is giving reproducible results in 15 lakhs, it's a good machine. If you don't have an optical biometer already with you, if you don't have an auto ref already with you, if you don't have an auto K already with you, this can give you even the central corneal thickness pachymeter, white to white, which can also help you into once the kid grows up, and vitreous thickness, all this, once you are planning to put a phakic IOL. So point is that it is giving good things. When I was talking with one of the research scientists who is responsible for the development, he said that they are also planning to put up similar progression charts into the software, and it will also let you know what it will also let you know is axial length upon CR ratio. So gradually they are taking notice of all the things that you are getting, and they are going one step further. Now if you see Maya, what Maya can do is it can also add on to this and give you a corneal, at least a Placido corneal topography. Apart from whatever is already there, it enhances your myopia management by giving you growth curves. So now you can plot your own patients on follow-up, and you can gradually generate the growth curve of the patient. So not that you particularly need this for your myopia practice, but any of the three devices, I don't know what are the costs they are placing at, but I think it is somewhere close to 24 or 25 lakhs. But we will, when we will be talking in the live session, we will discuss more about how important these are in your practice. At this point of time, I can just let you know that these are good machines. You can use them if you are trying to set up a separate myopia control clinic. If you don't have all these equipment, still you can easily build your practice. Easily you can build up your practice, because everybody, all of us, have an auto ref, have an autokeratometry. We all have optical biometers, A scans. So it is not that we need these fancy gadgets. The newer fancy gadgets clearly tell you that there will be more and more work in myopia, number one. Number two, if you want to have such charts like growth curves, normative growth curves, and comparable growth curves, what happened last time, you can easily get these charts in this. Or else you can tell one optometrist to sit, and like we have made our own sheet, you can make similar sheets and similar fancy growth charts. So not that you need these machines to give you growth charts, but they would be really invaluable if you have extra money, or if you are planning to invest into a myopia control clinic. Then these things would be really helpful. Binocular vision assessment, you have to do it at least NPA, NPC, AC by eye ratio, accommodative lag, and stereo acuity, or Worthford dot test, just to know that patient doesn't have any binocular, basic binocular problem, doesn't have a problem with near point of accommodation or accommodative facility, doesn't have high AC by ratio, because the moment you start them on low concentration atropine, because of high AC by ratio, they may start going into esotropia, accommodative lag, and cover test. So these are very basic things, but they should definitely be done before putting them on some sort of treatment. This is I mean, this was not introduced for myopia, but I think it is an extremely invaluable tool for myopia control clinic. I know it is pretty expensive, but and indirect ophthalmoscopy can do the job. Now peripheral fundus imaging, most of the myopic, this ultra wide field imaging is basically for peripheral fundus imaging. And peripheral fundus imaging, the problems of periphery are mainly seen in myopia patients. I don't know why. I have absolutely no clue why ultra wide field imaging is still not trying to target myopia clinics. They should, because ultra wide field imaging is most useful to people who are going to set up myopia control clinic. Now, myopia control clinic seriously has patients who are typically myopic, and myopia control clinic is basically not run purely by retina people. So they are basically run either by general ophthalmologists or pediatric ophthalmologists or optometrists. And these three, although they can see periphery with the indirect ophthalmoscope, it is much easier for them to use ultra wide field imaging and have not only record keeping, because it is very important to see the peripheral fundus of a patient who is myopic. Now look at this particular review of myopia management, which I was also trying to show you, I think in my second class, where I was trying to talk about how myopia increases the risk of serious sight threatening complication. And they have told what percentage, what diopters. Every diopter, you will see that it doesn't just double, it triples up. So the number of chances that you can have myopia, maculopathy, purely the macular problem, but retinal detachment, mainly due to the peripheral retinal degeneration, they go multifold as the myopia progresses. So I think when we talk about retinal complications, one of the points which is very important and striking is that if it is possible and if the budget permits, an ultra wide field imaging would be a very good thing and a very good a very good addition to the myopia control clinic, because then you don't really need to bend your back. And if you see that there is a problem in periphery, you can easily get those patients into your for laser photocoagulation or refer them to a retina colleague, and that way you have got a record that you have not missed out on anything. Having said that, it is a wonderful tool for easily screening the patients, but nevertheless the importance of indirect ophthalmoscopy does not go away, and a good indirect ophthalmoscopy is always useful. The two major advantages of ultra wide field imaging is that you don't have to sit there to do that. Second, you don't have to dilate the pupil, so they can come at any time. If you are going to dilate the patient, then might as well you should take your indirect ophthalmoscope and have a look. Where kids normally are not very cooperative for indentation or for peripheral examination, and here also ultra wide field imaging would go a long way in helping you out in getting getting the periphery imaged, so that it becomes easier for you to take up those patients where there is some suspicion. Now, how do you know which patient you want to start the treatment? Now, this will be based. We have already taken this up in the class on documentation and in classes of pre-myopia, where I was trying to tell you about the scoring system. But these are some simple things like age of the child, age of onset of myopia, family history, what is the baseline refractive error, baseline axial length, and environmental risk factors. So these are grossly the risk factor identification, where you can tell that this particular patient will progress and may progress definitely, and you can tell the patient that they have to come back after 3 to 4 months rather than after 6 months, just to know whether this patient is progressing or not. And every clinic does have their own follow-ups and does have their own ethnicity to know which patients progress in their particular clinic. So this also should be kept in mind. Make a list of it, talk about it, put it, paste it there as the risk factors which you feel are more common than other factors. Now, if you see this video, I had already shown this video before also. This is a BHVI myopia calculator, and this is a similar calculator is also available in other biometers also. BHVI has integrated with Myopia Master, but you can see that Maya of Topcon and OBM12 of Remedio also have their own myopia calculators. The news is that Zeiss is also going to come up with their own myopia calculator, but they will be coming in next year 2026. So these calculators are very useful when you have to tell the patient, number one. Number two, for your own self also, you can see what is there, who will progress, and then gradually you can actually validate whether in your patient that really happens or not. So once you validate that, it becomes much easier for you to go across the table and sit with the patient and try to explain it to him that, this is what was expected and this is what is my experience in my clinic, that this doesn't happen, and therefore you should go ahead and do a certain kind of treatment that you feel is good for that particular patient. Now, pre-myopia, I think I would not take it here. Just few things, we have already talked at length about it. Just few things that, we have to think about pre-myopia as an actual problem. We have to stem out the pre-myopia risk scoring system. We have to find out whether there is a family history or not, whether they are gradually losing out their hyperopic reserve or not, and try to tell them that it is the outdoor activities, reduced near work, frequent breaks, can be, these can be given. If there is a accommodative lag, you can give progressive addition lenses, although there is no great literature on how or how much it works. Now this is also taken up, I think, in the second lecture, the impact guideline which we together published in IGO. uh, these are pretty simple pointers, the same thing that we have been discussing in last 2.5 months. You have to identify a true axial myope, you have to map the risk factors, pick up the myope who is progressing, and then you have to think about the appropriate control strategy. Most important point here is to have record keeping, which is an essential part of myopia control clinic, that you should have records as to how much is the progression, and then you can go back and tell the patient that this is what is happening. Now, when to initiate, as I said, that there has to be classical evidence that this particular patient is progressing, number one. Number two, this particular patient is progressing and he is progressing axially. Only then we can start or think of starting an anti-myopia therapy. Now, when we talk about starting anti-myopia therapy, now we have to understand whether to start monotherapy in the beginning, or we have to go with combination therapy, or we have to think of triple therapy, depending on how quickly the patient is progressing, what is the change in axial length in last 6 months, and how quickly the axial length is building up. Now, that brings us to one of the most important questions: how to get the patients. How do you get these patients? That is the most common question which is asked whenever I talk about myopia control clinic. The bulk of the question is how to get these patients. Now, one of the most easiest ways to get school screening. I know that school screening you can get these patients, but the problem, it is very very important, but because schools are the place where you will get these kids, but the problem of school screening is that it never changes to bringing those students to the clinic once you do the school screening. So when I had started my practice in 2008 in Baroda, we in that particular year I think we did screen about 90,000 children, 90,000 children, and we could only get, and that was a trust hospital, and we could only get 140 patients to the trust. 90,000 children we screened, and only 140 children came to the clinic, and it was completely free of cost. Last year we did a school screening in one of the affluent schools, thinking that poor schools do not get we don't get patients to the clinic because the patient is poor, a patient doesn't have resources, he's not able to travel, and so the school screening work goes into dump. But we did go to a very posh school, one of the top schools of our city, and we saw I think around 1,200 children, and we could hardly get around 48 children to the clinic. This after doing school screening, this after being one of the few pediatric ophthalmologists in the city, this after 20 years of practice. So school screening may help, so it is worth a try. It may not help, so you should not think that why school screening is not working for me. Then you have to move on to other avenues, like in institutes. If you are in a group practice, as I said, if you have a LASIK practice, or if you have a cataract refractive joint practice where there is a retina surgeon also, and these patients who are coming for LASIK, these patients who are coming for refractive surgeries, obviously have kids who would be myope because they are coming up for surgery for myopia, and you can put up a signboard that myopia is progressive, your kids may have myopia, and their siblings and kids should be checked for myopia. So this is a classic case of internal branding. You can brand your own clinic by yourself and for yourself. So you can always say, you can make a novelty out of it, that every Thursday myopia control clinic, we run a myopia control clinic, and if you have children, your own children or your cousins or siblings, you can definitely bring them on board and we will do the checkup. Don't fall for free this thing. It doesn't work. It really doesn't work for kids. If they want to come, they will come, even paying the money. So it is not that if it is free, there will be hordes of patients. If it is paying, people will not come. For kids, they will come. That is not a problem. Most important is, and the whole purpose of starting myopia progression control course is to talk with your colleagues, to talk fellow ophthalmologists about high myopes, and to talk with retina clinic for high myopes, and thereby the patients which they have, and if their kids have myopia, they can refer those patients or those kids to your clinic. You can talk with your fellow ophthalmologists about all this. See, you are working on myopia control, and your fellow you so when I started giving atropine 0.01%, my own fellow ophthalmologist would say, oh, this is homeopathy, boss, then this really doesn't work. 0.01% is nothing, we have been prescribing 1%. 0.01% is like, diluting it enough to make it a homeopathic medicine. So you have to first talk among your own colleagues, so that they know that myopia control is there. There are certain myopia control glasses available, and they do work. Because the moment you tell the patient that there is a treatment, or there is something which can stop the progression of myopia, immediately the patient goes for a second opinion, and patient is invariably told that, oh, these are all experimental things, not really proved. These are all proved really useful things, and it becomes very difficult to convince them, to convince them that this works. Like pediatricians, you have to tell the pediatricians that myopia control works. You have to tell the pediatrician that, you have given atropine eye drops, you have given glasses, and this really works. And only then those pediatricians will tell the parents that yes, this may work, and you can definitely opt for a myopia control glass, or you can opt for low concentration atropine. Because if your colleagues, if the healthcare providers, as we all, have no idea that this thing works, we would not be telling the patient that this actually works and you should do it. So it is very, very important to not only create awareness among patients, but also create awareness among healthcare providers, pediatricians, ophthalmologists, so that they can also vouch for the treatment that is being given to them. Or in the process, if they also learn to do this for their patient, very good, wonderful. So the point is that if you don't tell them that this thing is really working, they won't either repeat, or they won't endorse what you have already told the patient. So it will never be fruitful, and will not bring the second line of patients. So I think all this can be done. Apart from this, these are all ways that I do it in my practice. I know a lot of my colleagues, they take up Instagram, they take up social media. Good, if whatever way it is useful, it is always a good thing to publicize about the disease, to make people aware. Whatever mode of communication you select, you can do it anywhere, everywhere. The core advertisement, or the core publicity, should be about the disease and about the awareness, and not truly about who is doing it. If the number of patients, if the number of myopes who want treatment increase, your practice is going to increase. There is no doubt about it. And good work has no substitute. If you are doing good work, they will come to you for a second opinion, for a third opinion, even for a primary opinion. If they come to know, even from newspaper, if they come to know that myopia is progressing, they will still come to you for an opinion, whether something can be done for their kid or cannot be done. So yes, we can be partners in crime. We can partner up for setting up myopia control clinic. We are open to setting up franchisees, or setting up the myopia control for others, or give advice how to do it. We can give training to the staff, give observation to your staff, to whomsoever wants to learn about myopia. We are working with OPM 12 Remedio people on myopia calculators to be incorporated into their OBM 12, very similar to what is already there with BHVI. Most of the data that we have will generate. We have already finalized the scoring system of pre-myopia. So pre-myopia, which I shared, I think when we were talking about chapter 3, when we were actually talking about pre-myopia, pre-MO risk scoring system, and we wanted to find out what is the critical scoring system for Indian population. We right now have the data, and now we are planning to do a multi-centric study, which we will be able to finish in a couple of months, to know more about it. But anytime, if anybody wants to make a myopia control clinic, or make a separate practice, we can definitely help them out. we can do things together. That is not at all a problem. So we are there for you throughout. Whenever we are needed, we can do it. So that's all regarding setting up myopia control clinic. And I think this will be one of the last talks, last lectures in this particular course on myopia progression control. We will be going for some small supplementary materials. I think we will be able to prepare that, and we will discuss it uh, once we have the live meeting. So thank you so much for joining this particular course. The response definitely was overwhelming, and I sincerely thank you for joining the first ever training program, online training program on myopia. And the whole purpose was to make a difference, and I think we will be able to make a difference once we all gradually go towards working out the solutions to myopia. So thank you so much and have a great day.